and I am pleased to introduce one of our newest members of the DAPS Medical Advisory Board. Dr. Jerome Lisk is a board-certified neurologist, director of movement disorders at MD Neurology, and clinical assistant professor at the University of North Texas Health Science Center at Fort Worth. He has 20 years of clinical experience in neurodegenerative disorders and 16 years of clinical trial design experience as a primary site investigator and sub-investigator in national clinical trials. His passion for innovation and business strategy keeps him highly motivated to advance the treatment and eventual cure for neurodegenerative diseases. Dr. Lisk also completed the Diversity Leadership Program, Trinity Leadership Curriculum, and is a graduate of the American Academy of Neurology Donald Palatucci Advocacy Leadership Forum. Currently, Dr. Lisk is obtaining his Executive Healthcare MBA, where he is enhancing his skills in healthcare finance, strategic thinking, leadership, conflict resolution, team building, and understanding healthcare regulatory challenges. Please help me welcome Dr. Jerome Lisk.
Well, thank you very much. I may have you email me that bio you sent me because that's a little bit better than the one I have. So thank you very much for everyone coming today. I would have been here a couple years sooner, but of course, like she said, I went back to school. So one thing that we always want to do is keep on learning. I'm really big on education. So let's get this. Okay. So we're going to talk about, I have several talks on Parkinson's disease, and one thing we're going to talk about are gender differences between men and women. This is a topic that's not really talked about enough because even though Parkinson's disease is more common in men than women, there are significant differences, and that can make a difference when we deal with therapy. Okay, so in 1817, James Parkinson had about 6 people walk by his office as he looked out his window, and he saw these patients walking by with a shuffling gait and tremor. And so he described this here as the involuntary tremulous movement with a stooped posture, with lessened muscular power, with a fenestrating gait, okay? And incidentally, he did not coin the term Parkinson's disease. It was a French neurologist named Charcot. So Parkinson's disease, the terms can be confusing because they have evolved over time. We initially called it Parkinson's agitans. Sometimes you'll hear Parkinson's disease, and patients will just say Parkinson's. And when people say Parkinson's, they'll say Parkinson's, and they'll infer to these other atypical Parkinson disorders. So we call Parkinson's disease, as physicians, we'll use the term idiopathic. And probably what we need to do is use the term more typical Parkinson's disease when talking to patients, because there's 2 main groups, typical, atypical, then there's a third group, secondary Parkinson's disease. So atypical Parkinson's disease has been called Parkinson's plus. When we refer to Parkinson's disorders in general, we can refer to them as Parkinson's disorders, Parkinson's syndromes, or Parkinsonism. When I talk to patients, people tend to like the word Parkinson's disorders more than the other 2. When we deal with multiple system atrophy, at first, pathologists, we described it, they used the word striatonigrodegeneration. That just is talking about the locations where atrophy happens in the brain, the pathological areas in the brain. Then we start calling it Shy-Drager. Now we call it multiple system atrophy, and there's 3 subtypes for that. Then we have Lewy body dementia, or diffuse dementia with Lewy bodies. And so this is an atypical Parkinson disorder, also like multiple system atrophy. But I wanted to show you these names because sometimes these names are used so interchangeably, and it could change from if you're in a hospital, if you're seeing a general neurologist, or if you're seeing a movement disorder neurologist. Sometimes, and if you're looking on the internet, sometimes it's easy to get confused. So Parkinsonism is when we have bradykinesia, unilateral tremor, muscle rigidity, postural instability, and also a mass face. So shuffling gait and a freezing gait can also happen in these Parkinson disorders in general. Not just Parkinson disease. These could happen in atypical Parkinson's as well. So when you're so it's about 85% are sporadic. Now about 15% are genetic. When I was in medical school, the percentage of genetic was 5%. Then when I was in residency, it was 10%, because we're finding more genes, more research is being done. Then by the time I got out of residency and fellowship and was practicing, about the first 5 years, that number jumped to 15%. So with more research and as we get more advanced scientifically, that number is probably going to increase. And I already said that men outnumber women. It's a 2-to-1 ratio, about 1.5-to-1 ratio men to women. In the United States, you need 2 out of 3. Bradykinesia is the main feature, the cardinal feature of Parkinsonism. People with essential tremor, they're not slow. Okay, that's one key difference. Then you could have tremor, or you could have rigidity and postural instability. Now, you don't have to have tremor. It's kind of a misnomer that everyone with Parkinson's disease or Parkinsonism has tremor. And remember, what I said before is that when you have, go back up, let's go to the previous slide. When you have Parkinsonism, these could apply to all the different Parkinson disorders, not just Parkinson's disease. And there's many. Okay, so you need 2 out of 3 for a diagnosis. A lot of people can just be slow and have rigidity. That's it, and have no tremor at all. In the UK, they have a long, big table that is more complicated how they diagnose Parkinson's disease. So the way we do it as physicians is you come into the office. We don't have a blood test. Like now you heard there's a blood test for Alzheimer's disease. We've been finding that Parkinson's disease and Alzheimer's a lot of times can coexist. So we have a blood test for that. They're trying to make a blood test for Parkinson's disease. A few months ago, they've gotten about 60% there on the blood test. But Parkinson's is diagnosed as a clinical diagnosis. So if you come into the office, we see that you have Parkinsonism, you have those symptoms. You may be slow, stiff, shuffling, and the other symptoms I mentioned. And sometimes which we'll get into later, we may have to do other diagnostic studies, but levodopa is a medication we give to people. Levodopa is an ingredient in many different medications that are on the market. And if you have at least a 30% response or more, then we know that person more than likely has Parkinson's disease. Occasionally, it could fool physicians because, like multiple system atrophy, sometimes you may get a 30% response, but that response will wane over 2 years. So really, when you get that big response, that response needs to be there continuously for at least 5 years to really say you really have Parkinson's disease. But that's how we test people. Let me go back to the previous slide. And so the main non-motor symptoms, non-physical symptoms that we have, we call premotor, as far as neurologists, are REM sleep behavior disorder, we have decreased sense of smell, and we have constipation. So, there's a lot of people that are constipated. Okay, you can't screen everyone as constipated, and people are a lot of times unaware of their sense of smell, especially men are more unaware of their sense of smell than women. But REM sleep behavior disorder is when you're acting out your dreams, and that could occur 12 to 20 years prior to the physical symptoms of Parkinson's disease. Also, REM sleep behavior disorder, if you act out your dreams, it's purposeful movements, that could indicate you have a 60 to 80% chance of developing a Parkinson disorder, Lewy body dementia, Parkinson's disease, or multiple system atrophy, one of those 3. So a lot of famous people have had Parkinson's disease. And Hitler's up there. I was incidentally looking at the History Channel. I like history. And there was a documentary of Hitler. And if you go back to the History Channel and you look at that, you can see there's a clip with his hands behind his back like this. And he has that resting, that slow tremor that was caught on film. And I don't think there's many instances where that's been caught. Brett Favre, that's not up here, has been recently diagnosed with Parkinson's disease. He's for you guys who don't watch football, he's a former quarterback, Green Bay Packers. Muhammad Ali and Michael J. Fox are the most common ones. Sometimes this does us a disservice as physicians because the public only knows of one thing, just Parkinson's disease, and they don't know that they could have another Parkinson's disorder that's not Parkinson's disease. And just incidentally, we can stay on this slide, just incidentally, they've done studies to show that if you're a movement disorder neurologist and you're trained, you do a 1 or 2 year fellowship in movement disorders, you're about 85%, going to be 85% right on the diagnosis. So it's still a 15% error rate where you could be wrong. General neurologists, it drops down to about 70-something percent or 67%, and it drops even further for other physicians that are not neurologists. So on the next slide here, we have, it's the second most common neurodegenerative disorder, Alzheimer's being first, 7 to 10 million worldwide, 1 million in the US, which is probably going up to about 1.5 at this point. And 0.3% in industrialized nations, 60,000 new cases per year. Mean symptom onset of about 60 years of age, and the prevalence increases with age. All right, so there's some interesting trivia. Usually when I'm doing this, sometimes I'll quiz the audience before this, but if you look at the Amish community, which they kind of more stay themselves, so it's more an enclosed community, not a lot of outward marrying and whatnot. So the genetics there pretty much kind of stays, that genetic pool is pretty consistent. So the Amish community has the highest rate of Parkinson's disease. Nebraska, where it's heavy in agriculture, and we'll get to a slide about that, pesticides, how that increases your risk for Parkinson's disease. So Nebraska has the most patients. And then Brescia, Italy. I don't know if anyone may even think, why is Brescia, Italy there? Because they have a manganese plant there. And there's manganese is a toxin that can cause Parkinsonism. And incidentally, people with manganese poisoning, they get Achilles tendon contractures, so they tend to walk on their toes. That's kind of one differential sign. But prevalence by country, USA, number 1. Then we have Japan, Germany. And then the countries with the least amount incidence of Parkinson's disease are Korea and Ethiopia. And so, well, why? Well, these countries at the top are more industrialized, we use more chemicals, we use more pesticides. And of course, in the USA, we've kind of Americanized Japan and other countries. And also, our FDA, when it comes to what you could put in your food and how you could treat your animals, is much looser than other countries. A lot of countries, chemicals and things you put in your food are banned, like food coloring, like yellow number 5, number 6. Other countries may use turmeric. And incidentally, those food colorings could increase your risk of cancer. So the growth is by basically 2030 is going to it's going to double in industrialized countries. You could see the U.S. 50 to 100% growth. You see Asia, Europe there, and then greater than 100% growth are those third world countries that are becoming more industrialized. So there's a big connection between the environment and risk of Parkinson's disease. So what risks do we have? Age is obviously a risk. Family history could be a risk, that 15% genetic I mentioned. Also, exposure to well water. When I was there, I went to medical school at Medical College of Virginia, and when they were training us as medical students, they said, hey, look, they want us to ask if the patients drank well water on the internal medicine service. And so it's more than just neurology. I'm sure residents in Los Angeles didn't have to ask that question. So pesticides, chronic head injury. There's something called chronic traumatic encephalopathy. So it's always thought, can head injury predispose you to Parkinson's disease? Muhammad Ali is an example, right? We look at football players. There's controversy on this, and you're going to see people on both sides talk about this. I think that it has to do more than just with repeated head injury, because if that were the case, almost every linebacker, which that has the highest G's of force when someone gets hit, the linebacker position, almost all of them would have Parkinson's right now. So it has to be more than just repeated head injury. And here we have REM sleep behavior disorder, constipation, impaired sense of smell, the top three. Depression and anxiety can precede Parkinson's disease. So people can be more depressed and anxious prior to having physical symptoms. Now, what tends to decrease your risk? I was at the Movement Disorder Society meeting years ago, and I saw a slide about coffee. And I wasn't fast enough to get a picture of it, but I did look at the slide and saw that I looked at the cutoff. And it appears in these epidemiological studies, people who drink coffee 24 ounces or more per day tend to have a decreased risk of developing Parkinson's disease, okay? So some companies, like, there's a drug called Neuriance that has tried to kind of mimic that, because they look at, how do some of these things affect receptors in the brain, and you try to mimic medications that may do that. Also, we have tobacco, but we don't encourage everyone to smoke. They found that smokers have a decreased risk of Parkinson's disease as well. But there's nicotine receptors in the brain. Anti-inflammatory medications like ibuprofen. This comes where there's a subject in movement disorders with Parkinson's disease where inflammation seems to play a part. And we know that inflammation seems to play a part with a lot of diseases. And this is something that does need more research, and we don't know that much about. Now, these things that decrease your risk, these things are not going to, I don't want everybody run into the coffee thing when you get out of here, because these things are not going to like treat your Parkinson's disease now. Okay, so these are people that don't have Parkinson's disease, and they see decreased risk. Now, people that may have daytime somnolence, or when we say excessive daytime sleepiness, I do encourage coffee, but that comes with a price of being a diuretic also. So this is a slide that's kind of hard to see, but these are just all the, I don't want you to have to read this slide because you probably can't really see it, but these are all the non-physical symptoms that you have for Parkinson's disease. You can feel free to take a picture of it so you can zoom in on it if you're at your seat. But one of these are neurogenic orthostatic hypotension. These non-motor symptoms have been proven to be more disabling for Parkinson's patients than the motor symptoms. Neurogenic orthostatic hypotension is when the blood pressure is not regulated anymore by the body. So it's erratic. It goes up and down all over the place. People stand up, they may get dizzy or lightheaded. Sometimes their knees will buckle, and there'll be no dizziness, no lightheadedness at all. I've had patients that are 40% of patients may be asymptomatic. I've had patients' blood pressure drop 50 points from sitting to standing, to the point where one guy, he was bent over like this, and he had to stay like this for literally 20, 30 seconds before he could stand up erect. And this is a big reason for falls. And when you go to the ER and they take your blood pressure, when orthostatic hypotension, when you lay flat, the blood pressure is high, the highest. When you stand up, it's at its lowest. So of course, when you go to the ER, you're laying on your back. So he said, well, the blood pressure is high. Give that person some blood pressure medication. Well, they don't realize that when the person stands up, now that blood pressure is going to drop even more. So they've done a study, at Lundbeck did a study showing how many people that had dizziness and falls are syncope, passing out. How many of these people, what tests did they get? And orthostatic blood pressures was almost the last thing done, if at all. People had CTs and cardiac echoes and EKGs and MRIs and all type of things. When the cheapest thing that didn't probably cost you a dime was the answer to the problem. Just doing the blood pressure laying flat for a minimum of 5 minutes, take the blood pressure and heart rate, stand up, wait 3 minutes, you take the blood pressure and heart rate again, and you see the difference. You're not interested in the number, just the difference. If it drops more than 20 points, then we know you have orthostatic hypotension. So symptoms of Parkinson's. So we have the non-motor we talked about. We have also decreased sense of smell could also happen in Alzheimer's disease and other diseases. So it's not just Parkinson's disease or Lewy body or multiple system atrophy. Cardiovascular sympathetic denervation. There's this MIBG, that's a cardiac nuclear medicine test that's not very available in the United States. GE Healthcare got the rights for that in 2013, but it's used heavily in Japan. And they could tell the difference between Parkinson's disease and multiple system atrophy because in multiple system atrophy, that MIBG nuclear medicine test is normal. In multiple system atrophy, well, it's normal in multiple system atrophy, but abnormal in Parkinson's disease. So hypophonic speech, where people get a low voice. There's Lee Silverman voice therapy. There's the Parkinson's Voice Project. And then we have small handwriting. The handwriting gets smaller and smaller. We're not talking about messy. A lot of times I ask patients, their handwriting is small. They say it's messy. Well, that's not the question. I'm asking, is it getting smaller? So handwriting getting progressively smaller. The poker face, lack of expression on the face. And you know, the spouses, the people that live with the patient rarely notice the poker face. Usually it's the kids that come visit every 6 months or 3 months or something like that. Decreased arm swing. And one thing that's kind of, a shuffling gait, one thing that's not really known, not talked about much, that when someone's walking, if they're starting having tremor in their hand like this, people with essential tremor, some Parkinson's patients will swing their arms, but if they start having tremor like this, people with essential tremor, their hands don't shake when they walk. And I've had patients where they were so good on the neurological exam, they're passing it, they're not giving me any clues, but they're walking. I see that little tremor when they're walking in their hand. And then unilateral foot dystonia is a cramping, like a Charlie horse. Anybody's ever had a Charlie horse? That's like a dystonia. The muscle cramps up and it doesn't let go. And it can be painful or painless. And it can happen to your toes, where your toes curl. It can happen to your calves, first thing in the morning. And YOPD is young onset Parkinson's disease that happens before 50 years old. If you have Parkinson's before 50 years old, it's young onset. And I will urge all of you, when you're talking to your doctors, make sure that they're not putting the onset of your Parkinson's as the diagnosis when you've had symptoms 3 or 4 years prior to that. Always put when you had symptoms, not when you were diagnosed. Okay, so here we have this graph, and at the left here, we have decreased sense of smell, which is hyposmia, constipation, REM sleep behavior disorder, and that is the premotor phase. That's the phase where you have no physical signs. Everybody looks normal, everybody walks and talks and looks normal. But in the brain, this process of loss of these neurons, not only that produce dopamine, but there's an area in the brain that produces serotonin that happens at around the same time in the first pathological stage when everything looks normal, that these neurons, see that line way up there on the left at the top, how it's dipping down, and then we have the motor symptoms, the bold line, dipping up. And so right about that intersection is where we're kind of diagnosing people, and then basically these non-motor symptoms are happening way before the physical symptoms. And they can happen anywhere between 5 to 10 years, well, probably about 5, 7 years prior. So this is a picture. The top picture is a normal cross-section of the brain. So basically, if I lay back like this and I'm slicing the brain this way, you're kind of looking down, okay? You're looking down. If I slice the brain this way, you're looking straight down into the brainstem. And that black area there at the top is called the substantia nigra. Those little, like, reddish areas up there top, that's called the red nucleus. And so you look down, and you see it's about as, some of that black line is faded. Those neurons that produce dopamine that have died, that have degenerated. When you have your first physical sign, about 67% of those neurons have degenerated and lost, they're gone, they've died. So it takes time for 67% of nerve cells to die. And that could be that 5, 10, sometimes 20-year process in the brain. The top slide is a pathological slide of all those dopamine neurons. You see the bottom one right below it. Now it's not so populated. On the right, you see that little red dot with a halo in the middle? That's called a Lewy body. All that dark red area is an abnormal protein called alpha-synuclein that is normally in the body to help the function of the nerve cell, but for some reason, the protein changes form and it starts to clump up in the cells. It becomes not functional. So this slide I wanted to show you, and basically we have pesticides, herbicides here on the left. MPTP, there's a book called The Case of the Frozen Addict. You could bid for $7 on Amazon, okay? A friend of mine, Michael Langston, wrote the book. And so the story of this MPTP is what really got us in the 80s to find out, to discover, well, they really broke the research about environmental exposure. Because the heroin addicts in San Francisco started to come down with Parkinsonism overnight. And not mild Parkinsonism, they were coming down with moderately severe Parkinsonism. And we know you can't get moderately severe Parkinsonism in a day or two, okay? So Dr. Langston, they start seeing these people coming to the clinic. They start seeing they were heroin addicts, and, they got some of the heroin, and I never asked them how he got it, but they got some of it, got into the lab, and they found this chemical called MPTP, and they gave it to these little rhesus monkeys, these primate monkeys, and all of them developed Parkinson's disease, and all their neurons, that bottom slide, were wiped out from those neurons that produce dopamine were wiped out. They didn't get diabetes, they didn't get hypertension, they didn't get cancer, they didn't get anything else. So it's like a bow and arrow. It went just right to that area of the brain. The rest of the brain being relatively normal. And then that really let us know about pesticides, herbicides that affect the mitochondria. Those PARC 1, 2, 3, 4, those are PARC genes that change the conformation of the protein that lead to cell death, and you have inflammation. So what we're saying is that your genes can be the gun, but the environment can be the trigger. So, when I was talking about Parkinson's disease happening prior to the physical symptoms, you see where it says pre-symptomatic phase 1 and 2. That arrow, that little pink area at the very, very bottom of the brain is where it kind of starts. And in that area, you have that thing called the locus coeruleus and dorsal nucleus. So dopamine and serotonin. Many times, Parkinson's is looked at as a one-dimensional neurotransmitter disease. Dopamine, 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 dopamine. we know there's more involved than just dopamine. We have then in stage 3 and 4, that's when people have their physical signs. The time between A and B can be, like I said, it could be about sometimes 20 years. Because when people have acting out their dreams, they're in this first stage up here, 1 and 2. And that acting out your dreams can happen one time and not happen again for another 20 years. So it's important to tell your doctor about it that, yeah, it happened 10 years ago, he never or she never did it again, but that's a sign. And it does not decrease your risk that it never happened again. And this is when Parkinson's disease then spreads to the rest of the brain, where you have hallucinations, you get difficulty thinking, you get orthostatic hypotension, and all these other things that come with it. So, I was going to talk about the difference between men and women in Parkinson's disease. This is not necessarily it, but you have a headache generator, and women a shoe generator. The male brain, you got, we have 2 areas there for sex there. You have the TV remote control area in the brain. I guess that area in the woman is called there's a gossip control gene there. And so this is a little, no. But seriously though, the differences are that, and this is going to be hard to see, but there's differences in motor symptoms, non-motor symptoms, and psychological issues. So this is a little bit easier. This has everything the previous slide had in it. Men are 1.5 to 2 times more common. Men have more bradykinesia and rigidity on presentation. Women will have more tremor. With levodopa, women will have more dyskinesias. Women may have more depression and anxiety, but that's true for mood disorders in general, I believe, in psychiatry. REM sleep, men will have more acting out their dreams. Now, incidentally, when you act out your dreams, you have a higher risk of psychosis, dementia, and autonomic nervous system dysfunction. That neurogenic orthostatic hypotension I mentioned earlier, that's autonomic nervous system dysfunction, or automatic nervous system, if you want to call it. We have, let's see, what's another thing here? So, women are diagnosed about 2 years later than men. But women, it's well known that women are kind of minority in medicine, and that even when you look at women going to the ER that are having heart attacks, a lot of times women are looked at as being hysterical or anxious, and the same exact clinical symptoms a lot of times in men, they're given medications for heart attack, and sometimes women are given anti-anxiety medications. So that's not surprising that women are diagnosed later. Just go back to the previous slide. So, and also, slowness of movement seems more resistant to treatment for DBS. Women have more postural instability and more freezing. And of course, we have men have slightly more behavioral problems. So differences. There's no differences in psychosis, development of psychosis or severity of psychosis in Parkinson's disease. And within 10 years, about 50% of patients can get psychosis and dementia. It's hard to have psychosis without dementia in Parkinson's disease. So when people are having hallucinations or delusions, which are false beliefs, chances are they're more likely to have dementia. Men are more likely to receive antipsychotics than women. Women will receive antidepressants. Of course, we know women live longer. Amantadine could cause more fetal defects because we know that young onset Parkinson's disease, there's people that develop Parkinson's disease in their 30s. So pregnancy can be an issue. We have also up there, let's go back to the previous slide. We have Parkinson's disease can permanently worsen without affecting overall disability. Estrogen replacement therapy in postmenopausal women may have lower risk of dementia. However, it appears that estrogen may play a protective role in developing Parkinson's disease. That's what's thought. It's not proven. Increased risk of Parkinson's disease with progesterone only pills versus estrogen replacement therapy. Women require less caffeine than men to reduce their risk. And of course, decreased estrogen, fertility, longer pregnancies greater than 30 months. So through all the different stages, we know we can have young onset Parkinson's disease. Through all the different stages, there's things that need to be taken into account when it comes to women. So we have, family planning, worsening premenstrual symptoms, pregnancy. People have gotten pregnant when they had Parkinson's disease, so that's something to be taken into account also. Then you have the perimenopause and the postmenopause phase. All these have different issues at each stage, and you have to take these different stages into account and what's going on in these different stages when it comes to women, unlike men. So cost. So direct and indirect costs in Parkinson's disease can be almost $25 billion a year. Therapeutic surgery could be up to $100,000 per patient. Now, fortunately, when I look at deep brain stimulation, I really don't see patients having a lot out of pocket for that. I don't have patients really complaining, so it seems to be pretty well covered. It seems like deep brain stimulation is probably better covered than medications for some reason. We have the major impact on patients' careers, poor quality of life, loss of income. Most of these costs are, we see nursing home and outpatient medications. So, secondary Parkinsonism. Here's the book, The Case of the Frozen Addicts by Dr. William Langston, one of the nicest guys you ever meet, and smartest. So we have post-traumatic Parkinson's disease. People frequently ask me, well, I had 2 concussions. Is that going to increase my risk of Parkinson's disease? I can't say if there's some type of special thing with someone's genetics that may unmask Parkinson's disease. But I believe personally, professionally, that if you have 1 or 2 concussions, that's not going to cause Parkinson's disease in you. We have vascular Parkinson's disease, which is debatable whether that even exists. Hydrocephalus, and then we have space-occupying lesions like tumors. So there could be tumors that cause Parkinson's disease. I've seen also a large aneurysm to cause Parkinson's disease too. Also, we have the Parkinson's plus or atypical disorders, multiple system atrophy, we have Lewy body dementia. Multiple system atrophy, what you have in that situation is you'll have either a suboptimal or no response to levodopa. You have early autonomic dysfunction, such as urinary incontinence, or the most common one is the orthostatic hypotension. We call it neurogenic if it's happening with a neurological disorder. And then less common is corticobasilar degeneration, where people have stroke-like symptoms. They have spasticity, that dystonia I mentioned, like a Charlie horse in different muscles. Progressive supranuclear palsy, where you're falling just a lot earlier in the first 1 or 2 years. You're following they may fall 10 times a week or something like that. And also the early dementia, and they can't look up and down with their eyes with their head still. There's decreased eye movement vertically. And then you have frontotemporal dementia with Parkinsonism, which slips by a lot of neurologists, especially if you're probably a general neurologist. In that situation, we may do a PET scan, and there are blood tests you may be able to do to kind of find out if you have that. I've seen post-encephalitic, someone had encephalitis. That's only like 1%, so that's not going to be very common. And then you have the toxins here. So when we talk about the toxins, we talked about Nebraska having a high agricultural state. They've done something called an odds ratio. I know Jeff Bronstein at UCLA has done a lot of research in this. And when they drop a pesticide someplace in some of these fields, or say someone's using rotenirone or something in your neighborhood. There's a certain number of miles that they've calculated that where your risk is increased. So your risk could be the same, probably a block away as a person dumping it right in their backyard. We have rotenirone and paraquat are probably the most common ones. There's the chemical organic solvents. So a lot of stuff at Home Depot, Lowe's, can cause that too. And when we look at the bottom one, TCE. That's something that if you pay attention to Camp Lejeune, the news lately, that was in groundwater there. So TCE is used for dry cleaning, dry cleaners, and other industries, and it can increase the risk as well. So one of the Army bases, Camp Lejeune, is famous for that. Drug-induced Parkinsonism. Medications could cause this, and they're all reversible, by the way. Some of these medications could also cause tardive dyskinesia, but Haldol, I frequently see patients going to the hospital that have Parkinson's disease, and they're given Haldol or Risperidol because they have dementia or behavioral problems. You need to know these medications, and organizations like the Parkinson's Foundation, American Parkinson's Disease Association, certain of these Parkinson's organizations, they'll have a card, and they'll have a card with all these medications to avoid on it. So the ones we see frequently is Abilify, which is used frequently for depression, and Depakote is another one. Depakote is one that you have to be on it for about 7 to 10 years before you really develop it, and it could cause significant cognitive decline as well. So the answer is to stop the offending medication, and it usually goes away in about anywhere from 2 weeks to probably 6 months, something like that. So what is a DAT scan? Remember I mentioned that Parkinson's disease is diagnosed clinically? Well, here's a little tool, because sometimes especially in rural areas like Tyler or even places like Denton, Texas, where I practice, in Denton and Flower Mound, people will come to you and they'll be very mild, extremely mild. Or I've had an Alzheimer's patient in Los Angeles I was seeing that was shuffling, but she had a really bad back. So I couldn't tell if it was her back or in her hip or if she had Parkinson's disease. So I did a DAT scan. And they do this at UT Southwestern. They do this at Texas Health Presbyterian in Denton and Envision and some other places. And so they give you a thyroid blocking agent about an hour before, and they inject the DAT. You kind of wait around for an hour, and they inject the DAT scan, and you kind of have to wait around again. Then about 3 hours later, they do a SPECT imaging. This is a nuclear medicine scan. This is about 95%, about 90% sensitive. So everything at the top is abnormal, everything at the bottom is normal. So we could tell the difference between drug-induced Parkinsonism and Parkinson's disease. What drug-induced Parkinsonism and drug-induced Parkinsonism and Parkinsonism, because normal fish hydrocephalus, essential tremor, and everything, Alzheimer's, everything will be normal. The only thing that'll be abnormal are Parkinson's disease and the atypicals. So it's kind of, it's needed to accurately diagnose and timely diagnose people, because you want to give them the right therapy. You have to talk to people about what's going on in their life so they can plan. And you don't want to have to give people unnecessary medications. You want to reduce the cost, because all these medications can be expensive. So the most common causes of death in Parkinson's disease can be pulmonary infection, aspiration, pulmonary embolism, falls and fractures, and urinary tract infections that go into the blood cause sepsis. So if you start having daytime drooling that's moderate, that's an indication of swallowing dysfunction. And about 60% of those people can have silent aspiration. You could be aspirating and not even know it. So it's always good to get a swallowing study when you have daytime drooling. Not nighttime drooling, daytime drooling. So we're going to go through this. So this is just not going to go through all these. Not going to go through all these. These are just different medications. Some of these medications are out there in the hallway, but these are just some of the different medications here that you have for Parkinson's disease. and for different, all different aspects, psychosis to autonomic dysfunction, and there's new ones coming out every day. And I'm running a little bit over, so very quickly, these are therapies for drooling, neurogenic orthostatic hypotension, dementia, and psychosis. There's medications for those. Next slide. There's non-pharmacological treatments, Lisa and voice therapy, Tai Chi, Qigong, yoga, rock-steady boxing, dance for PD, cycling, light weights. All these exercises do something else. People that dance, play soccer, they rarely fall. Rarely fall. So, and next. Okay, and that's it. So if we have any questions, I'm sure we'll have an opportunity for that later.
Thank you so much, Dr. Lisk. It's been such a pleasure to be able to work with Dr. Lisk, so we're very thankful for him. Keisha, how are we on time? Okay. Do we have time for any questions, or is that something we need to? We do have some questions? Okay. 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 Excuse me. Sorry.
Oh, hi, I'm sorry I forgot your name, but the young lady up there, she said your treatment works, the thing works 16 hours. Why 16 instead of 24 hours? Isn't that correct? Wasn't that you?
No, that may have been.
Oh, I'm sorry.
That may have been.
Oh, did she leave?
It may have been the other.
Well, what I was wondering is it not necessary to treat when you're asleep? Is that why 16 instead of 24 hours? That was for the Duopa.
Oh, Duopa. The Duopa you could keep on as much as you want. Some people may. It's a pump, so you could schedule it for different times that you need it. And so the scheduling could get a little more complicated. That's something you have to kind of sit down and kind of talk to your doctor about, because it's different for everyone. There's boluses, there's different amounts. So, yeah.
I was just wondering if it had something to do with sleeping 8 hours, if you can.
No, I think that, there's some people that may have the pump going all the time. It depends on the person. Yeah.
Okay, well, thank you.
Therapy's individualized. There's no cookie cutter. The only therapy that works right away is somebody that's early. You give them Cinemet, which is carbidopa levodopa, and people, if they have Parkinson's disease, everybody's happy and everybody looks like a superstar. But you give people too much, and then you get these things called motor complications, dyskinesias, off time, and then you get into trouble the higher that levodopa is. So.
You were talking about dancing exercises, and there, the very last one said art therapy.
Yes, art and music therapy has been known to help people with cancer. So when you have positive moods, it definitely affects people's immune system. There's a thought that the immune system plays an important part in Parkinson's disease. When people are happier, their stress levels go down. And so, when you're listening to music, it invokes an emotional response. And that emotional response has effect on neurotransmitters in the brain, and also stress hormones in the brain. I think some of these stress hormones could be harmful. We've seen that with people that have heart attacks. People have an increased incidence of heart attacks if they have depression, stress, anxiety. They're more likely to have another heart attack in the first 2 years. So, and we've seen with cancer that music and art therapy works very well for patients.
Okay.
Thank you for being here.
Yeah, thank you.
I have two comments. One is really good, is laughter.
Yes.
Laughter changes your whole day.
Yeah. Some of my patients in here know that I kind of like get silly in the room. So.
And the Duopa at 24 hours, that's me.
Okay.
And it works just fine.
Okay. So you have an example here, sir. You have an example here where she keeps it on 24 hours.
Yes. And I'd be happy to talk to you about it after.
Yeah.
Sure.
We had one over here, this lady or somebody, this guy back here.
I'm glad I wore tennis shoes.
I'm just curious about drooling during the day, and what you're talking about treatment, if there is. I took a medication. I don't remember what it was called, but it was a nasal spray, and
Yeah.
I don't think it was great. But
So people could use something called a scopolamine patch that you do every 3 days. You could use something called glycopyrrolate. There's a tablet in a liquid. You could use botulinum toxin right here in the parotid glands. And then if that doesn't work, you do the parotid and the submandibular glands. It's pretty easy. There's a bone right here, your jaw. You just go right behind it. It's not complicated. And so the thing, daytime drooling has been linked to silent aspiration, not only in stroke patients, they have silent aspiration too, but in Parkinson's disease, when you have daytime drooling, that gets significant. That's definitely indicates you have swallowing dysfunction. People get a little numbness area in the back of the throat. I won't mention the name of the area, but in the very back where your gag reflex is. And so when liquid or food hits that area, you don't have that compensatory cough or where you try to clear your throat. And I've seen video stroboscopies with ENT doctors. They have videos of this. You can look at it on YouTube. It just slips. They color the liquid, and it just slips right down there into the vocal cords, into the lungs. No cough, no gag, no nothing. So it's important to do that. And so you go to speech therapists. And you could chew gum, and you can suck on hard candy if it's mild, and that'll force you to swallow. The problem is you're not swallowing frequently enough. So if you can remind yourself to swallow frequently enough or use hard candy or gum, that minimizes it.
I realize there are several more
I
questions.
had one person
We'll-
over here somewhere.
I think our time is about up. Will you be here to be able to answer some more
I'll be in
questions?
the back. No problem.
Okay. So please make sure we'll be taking a break shortly, and we're ready now. Okay, so we'll go ahead and take a break now. Please make sure that you stop by and see all of our vendors. Make sure you have your passport signed, and we've got a basket right before you leave where you can drop that in. We have a couple of great raffle prizes. And please make sure you stop by the DAPS table to make sure you're signed up for our newsletter and you can learn about our fall fundraiser. We will see you in 15 minutes.